That's it from me. Nosisa, welcome and take it away.
Thanks, Jeremy. Good afternoon, everyone. And thank you for spending this precious afternoon with me in this topic. So when I was given this topic, I have to make a disclaimer that most patients that I see are either allergic to peanuts, avocado, and certainly the majority of my patients at Bara seem to be allergic to tinned fish. And the sole management I give is stay away from tinned fish then, and I don't investigate it any further. But so in terms of this topic, I really would welcome your experience, your expertise, and we'll be taking questions and comments throughout, so we don't have to wait until the end for the comments and questions. And I think, Jeremy, then I will leave you to manage that side of things, and then you can stop me anytime, and then we will take the comment or question. All right. So for an introduction, in the literature that I found, it's actually quite well documented that most of the prevalence studies, and most of the studies regardless, are from the developed world, and there's very little coming from the developing world on this. But from the developed world, it is stated that penicillin allergy is the most commonly reported medication allergy. 10% of all patients and 15% of hospitalized patients. However, when these patients who report a penicillin allergy are thoroughly evaluated and evaluated further, the majority of them are actually not allergic to penicillin. So having said that, though, penicillins are among the leading cause of drug-induced anaphylaxis, and that includes fatalities. It has been decreasing over the years, and so it is quite important that we have a systematic approach to the evaluation of penicillin allergy because of the severe adverse event of anaphylaxis, even the other adverse events. And also there's adverse events to having that label of being penicillin allergic if you actually are not. So if we look at adverse drug reactions overall, there's this particular classification that looks at them as either being on-target adverse drug reactions or off-target adverse drug reactions. The on-target ones are what we expect from the drug. And so we've got that on the left, and the example that's over there is Clostridium difficile associated pseudomembranous colitis, just from the effect of antibiotics on the microbiome. The off-target effects, you then have non-immunologically mediated hypersensitivity reactions. And some of the examples there, if we look at that first picture over there, we've got aminoglycosides causing acute tubular necrosis. And the other example there is from fluoroquinolones that actually is not an it's non-IgE mediated, but they stimulate mast cells directly and cause degranulation. Then the ones that we are interested in for this talk is the immunologically mediated hypersensitivity reactions. And so you've got antibody mediated ones and then pure T cell mediated ones. And then by definition, an allergic drug reaction is defined as a specific immunological reaction to the drug. There's also a drug pseudoallergy, and these can be quite difficult to differentiate from a true allergy because the reaction can be similar or identical in presentation to an immunological reaction, but it's actually not immune mediated. So as clinicians, this is what we would have to differentiate from proper allergy, especially with patients that have comorbid illnesses and are on comorbid medications. And if such reactions are reported, to now differentiate whether it was immunologically mediated, was it the penicillin per se, or was it another drug, let's say from looking at vancomycin with the flushing that occurs during infusion. And some of these medications can even give anaphylaxis. Yeah. Looking at the pathogenesis, and we're just going to, there's a number of different ways that drugs can act as immunogens. And we are going to focus on for example, penicillin. And penicillin actually acts as in that column there with a direct hepnation of the drug. And then it is then further divided into the types that we know, type 1, type 2, 3, and 4. And 4 is further divided into subtypes. So homing in on that mechanism, if we look at penicillin, and most drugs in particular, they have a small molecular weight. And so they have very simple chemical structures and are not easily recognized by the immune system. And then the immune system does not recognize them in terms of the immune receptors. And thus there is no activation of your T and B cells. However, these small molecules can bind covalently to larger molecules, whether it be in the plasma, intracellularly and extracellularly, and they bind to host proteins. And any drug that then binds to these host proteins is then called a heptane. And then the heptane plus the protein is called a heptane carrier complex. And this complex is the one that is immunogenic to T cells and B cells. So with penicillin allergy specifically, penicillin heptanates plasma proteins directly. And at the top there, we've got the beta-lactam structure of penicillin. So when penicillin is administered and in physiological conditions within the body, the beta-lactam structure, the ring structure opens up, and then this reacts then with lysine residues in proteins, forming the heptane carrier complex. This heptane carrier complex is now called the major penicillin determinant. And this is quite important, as you'll see later on in terms of testing for penicillin allergy. This is responsible for 90% of penicillin allergy. So this heptane carrier complex stimulates T and or B cells, and then manifests in allergy. The rest of the penicillin molecule, whether it be the side chain or penicillin itself, are then the minor determinants that also then cause allergic reactions, but they are only responsible for 10% of allergic reactions. Also important in testing for penicillin allergy. So this is the mechanism in the majority of immediate allergic reactions to penicillin and other beta-lactams. So homing in on type 1 or IgE-mediated immediate drug hypersensitivity that can be responsible for anaphylaxis. And this is what I'm predominantly going to focus on the type 1 hypersensitivity reaction. So at the top there, you've got the heptane carrier complex that we've mentioned. So you've got the free drug that combines with the protein, and then you've got the heptane carrier complex. So this will then bind to IgE and be processed by B cells, which will then present it to T cells. And in that process of this antigen that's presented to the T cells, you get a cytokine, release of cytokines. And the interaction between the B cells and the T cells, you would get a maturation and proliferation of the B cells and class switching to then forming this specific IgE that would then be specific for this heptane carrier complex. The IgE then diffuses into the body and attaches to mast cells and B cells and waits for this heptane carrier complex again. So on the left, you've got the sensitization stage, which would be asymptomatic. But once the patient has been sensitized, is then waiting for at any particular repeat exposure, whereby then you can have this heptane carrier complex binding to the specific IgE and massive mast cell degranulation and immediate allergic reaction. So if we look at the penicillin structures, we've got the basic beta-lactam ring that is for all the beta-lactams. And all the beta-lactams predominantly have this structure except for monobactams. Then you've got the side chains, and these are different for the different beta-lactams, but some of them would share that side chain. So the allergic components would either be to the beta-lactam ring, in which case you would expect a cross-reactivity between your penicillins, cephalosporins, and carbapenems, and not the monobactams. And then if it was an allergic reaction to a side chain, you would then need to know which of the beta-lactams have similar or identical side chains. And there are cases where patients are selectively allergic to a particular beta-lactam and not the rest. And the ones that are described are selective allergy to aminopenicillins. This is reportedly very common in Europe, not so much in the US. And patients that are just selectively allergic to clavulanate, and patients that are, especially patients that have got cystic fibrosis, that have got selective allergy to anti-pseudomonal drugs like piperacillin. So this structure of the beta-lactams and the side chains would be important in evaluating cross-reactivity in terms of what antibiotics in future the patient is going to be given. If anybody has got experience in any of this, they are welcome to pitch in to just share some of their experiences and what they've encountered. And in the meantime, I'll keep going. So you've got at the top there looking at the fact that, you know, if you are allergic to penicillin, so less than 2% of patients would then be allergic to cephalosporins. And cephalosporins with carbapenems, you've got less than 1%. And no reaction with the monobactams. Historically, hypersensitivity drug reactions have been classified based on this Gell and Coombs classification. And so that is the different types 1, 2, 3, and 4, with type 1 being IgE mediated immediate type hypersensitivity. And that's the one that gives the clinical features of anaphylaxis, angioedema, bronchospasm, urticaria, hypotension, and involvement of other systems as well, like the GIT system. Type 2 is antibody mediated, but it's different antibodies to IgE. So this would be IgG mediated. And the clinical features would be hemolytic anemia, thrombocytopenia, neutropenias. Type 3 is due to formation of immune complexes, and some of the clinical features there are serum sickness and Athers reactions. And then type 4 is a cell-mediated or the classical delayed hypersensitivity type of reaction. And the serious ones are the severe cutaneous adverse reactions like Stevens-Johnson's and toxic epidermal necrolysis. And then you've got and even DRESS, drug reaction associated with eosinophilia and systemic symptoms, interstitial nephritis, but less severe reactions as well, like rashes. So the World Allergy Organization has got quite a useful functional classification, whereby everything is just divided into whether it is an immediate reaction or a delayed reaction. So we expect the immediate reactions to occur within an hour. If the penicillin or whatever drug was administered orally, especially with food, that could be delayed because of delayed absorption, and that could take it up to an hour. But classically, anaphylaxis occurs within minutes. And that's the type 1 IgE mediated that we are most interested in because it can cause anaphylaxis. The delayed reactions usually occur after an hour. It's usually more than 6 hours, and some of them can occur weeks to months afterwards, and even after the medication has actually been stopped. And the mechanism there would be the different other mechanisms as mentioned. So if you look at the scale of this problem a bit, interrogated a bit further, the penicillin reaction rate is reported as 0.5 to 5% of penicillin administrations, and that's in developed countries. And 5 to 15% of patients carry a penicillin allergy label. Most of these reactions cause a delayed drug reaction and drug viral interactions, with the most famous one being with EBV, whereby if a patient has got Epstein-Barr virus infection and they are given aminopenicillins, they then have this rash, which then becomes a bit difficult to differentiate from an allergic reaction if the patient was not known to be having EBV at the time and was just thought to be having some acute febrile illness, and the reaction is then ascribed to the antibiotic that was given. With regards to cephalosporins, in patient charts that have been reviewed in large surveys, 1 to 2% of these patient charts report a cephalosporin adverse drug reaction. So when we look at the IgE-mediated hepatosensitivity reactions a bit further, anaphylaxis is actually quite rare, being reported as 0.01% for parenteral exposure, and even lower for oral exposures. This has decreased over time, and it is thought that it's because the newer formulations are less allergenic. And in fact, the drug developers have really made a concerted effort in terms of the beta-lactams to make sure that they are less allergenic. And the earlier cephalosporins were apparently also contaminated with a penicillin, resulting in higher initially reported rates of cross-reactivity between penicillin and cephalosporins. If you look at the anaphylaxis rate with regards to oral exposure, it's so much lower. And over time, we tend to administer beta-lactam antibiotics and penicillin orally, or even IMI rather than intravenously. So that is also thought to have contributed to the decrease in anaphylaxis over time. So some of the risk factors that have been proposed. So age is a definite risk factor. Anaphylaxis is higher in patients aged 20 to 49 years. So perhaps that is why I haven't encountered one as yet. And this is thought to be just from a frequent repeated exposure, cumulative exposure as the patient gets a bit older. And then also there's a hypothesis with regards to whether is it because of an age-dependent difference in immune response with much younger kids. Some patients have what is called multiple antibiotic allergy syndrome, whereby they've got multiple allergic reactions to antibiotics that are not related of the same class. They could have an allergic reaction to a beta-lactam and to doxycycline, or just antibiotics that are completely not related. And so these patients have got a higher rate of anaphylaxis. And it's not known why, whether it could be from an HLA or a genetic background, why these patients, though it's not been identified as what is exact mechanism why they are so allergy prone. The evidence for heredity is quite weak. And then there's increased incidence in female patients in adults, and the sex effect has not been demonstrated in peds. There's an equal rate between males and females in pediatrics. It's also been reported that patients that are Caucasian have a higher incidence of anaphylaxis. Looking at patients that have got atopy, so there's no link that has been identified. However, patients that are atopic have more severe reactions when they do have anaphylaxis. And we've already mentioned the increase with parenteral administration. And then there are certain conditions that are associated with penicillin allergy, and went over them on the previous slide. Other considerations when dealing with a patient that is reporting a penicillin allergy or is recorded as being penicillin allergic is whether this is a true allergy or could it be an intolerance, like the GIT symptoms that patients can get with clavulanic acid in Augmentin. Is it possible that the patient actually had a viral exanthem and the rash was not part of an allergy? And then the drug infection interaction that I've mentioned already with aminopenicillins and Epstein-Barr virus. So mild delayed reactions rarely recur with a rechallenge. And this is thought to be that perhaps they were never part of the adaptive immune reaction to begin with, or with the lack of ongoing drug exposure, that this sensitization has been lost in time. One very important thing is the fact that, true allergy actually wanes over time. So if you look at patients that were skin prick positive for penicillin, so confirmed to be allergic to penicillin, these patients 10 years later, 80% of them will have lost that allergy to penicillin, and on further skin prick would be negative, and even with oral challenge would be able to completely tolerate penicillin. Similarly, for cephalosporins, in 5 years' time, 60% of them would have lost their allergy. So looking at the impact of patients that are truly penicillin allergic, or even that have got this label of being allergic to penicillin. So it's been shown in a number of studies, specifically in the first world, and this is quite intuitive, that these patients get increased treatment with broad spectrum antibiotics, such as fluoroquinolones, vancomycin, macrolides, clindamycin. And in one UK study that was published in the BMJ in 2018, they had almost 400,000 patients. And they were able to demonstrate that these patients had significantly increased rates of MRSA and also C. difficile colitis. So patients that were either penicillin allergic or had a label of penicillin allergy had an increased rate of this. Another study that was published in 2014, done in the US, in addition to these findings, they also documented that the patients experienced more vancomycin-resistant enterococci, and then they had a longer stay in hospital. And this was all ascribed to the fact that they received these broad spectrum antibiotics. Needless to say, this would then be, as already documented in these studies, be associated with an increased risk of antimicrobial resistance, increased healthcare costs, and also adverse patient outcomes. because specifically there's certain infections where penicillin is the drug of choice, and alternative drugs don't really are either not evidence. There's no evidence to show that they cause good outcomes, or they are known to not have good outcomes at all. And one such infection is neurosyphilis, where you need to be treated with PenG. And in the setting of pregnancy, syphilis in pregnant women. An alternative would be erythromycin, but erythromycin doesn't cross the placenta very well. So that infant would still be, it will treat the mother if she actually takes the oral treatment, but the infant may still get infected and the adverse outcomes there, and the infant would need to be treated. Same thing with surgical site prophylaxis. And there was one study that showed that patients that had this allergy label were then not given cefazolin as indicated, and were rather given either vancomycin or clindamycin, and these patients experience higher rates of post-operative surgical site sepsis. With Staph aureus endocarditis, apparently the outcomes with, and this is sensitive Staph aureus, the outcomes are not as good with vancomycin as compared to cloxacillin. And the same thing when you do secondary prophylaxis for rheumatic fever. It's been documented that these patients, as much as they can receive macrolides and the alternatives, sometimes then they don't take it because it's a daily oral treatment, and then they present with more relapses. So I would welcome your comments, questions in terms of the experience that you've had with regards to this impact of penicillin, or even other alternatives that are used for patients that are allergic to penicillin.
Yeah, so if anyone wants to share an experience, just stick up your hand and I'll unmute you. Certainly, Nosisa, I mean, I couldn't agree more with this slide. I mean, I think that it's described so many studies showing much worse outcomes. Well, substantially, let's say, worse outcomes with patients who have penicillin allergies. And it really kind of talks to the importance of making sure and ideally confirming if someone says they do have a penicillin allergy, because so often the alternative drugs are not as good, as you rightly say. And so they really, you know, in addition to just failures, as you said, there's also the stewardship issues and the C. diff and MRSA, but often just the primary efficacy is lower. And I've got, Jeannie Elliott, you can go ahead and unmute.
I'm sorry to worry you. We've got a heck of a lot of neurosyphilis in the Northern Cape. I've never seen as much as I see here. And we're having real challenges getting hold of PenG at the moment. Is anybody else also experiencing these problems? Because the treatment of choice is PenG, but there isn't any available for us to purchase.
So I think my experience as well is more with trying to find PenG and trying to find penicillin, not because the patient is allergic, but just this sort of lack of penicillin. We are experiencing the same problem everywhere. And as a pediatrician, it's more from having to treat the baby who's got congenital syphilis, and we are struggling to get penicillin. I'm not sure if anybody has got a secret stash anyway, or advice on how to get this PenG.
No, it's an international problem. I mean, it's the profit margin is so slim on penicillin G that, you know, that it's forever falling in and out of accessibility, and so no, it's across the country, and many countries suffer the same problem, sadly, and so you often have to use the alternatives, even though we don't think they're as good. Duncan Chanda, you are welcome to go ahead and unmute.
It's okay. I read that by accident. Thank you.
Oh, sorry. Okay, no problem. Yeah, I think that's it for now, Nosisa. But yeah, I think I agree fully with this aspect here, that the impact is not benign, you know, on just changing a drug. You know, there's often, it's not appreciated how much damage this does, especially when you consider how few people who say they're penicillin allergic actually end up being at least being able to prove it by skin test or other methods. I don't know, you may come to that in a bit. But yeah, all right, go ahead, I think, yeah.
So I think, yes, there's this move then to actually accurately label people and delabel people because of the impact of this label of penicillin allergy. And of course, patients that are truly penicillin allergic, and if they do need, and they've been evaluated as such and proven as such, then, you know, when you do need to get alternatives, you can do that. But in cases where you can't get the alternative, then you can go on to desensitization. So it then, you know, from the previous slide really sort of underpins the importance of proper evaluation of a patient that is allergic to penicillin. And this would start with a history. And some of the patients can actually be declassified from this stage already. And the questions that you would need to know would be, what was the patient's age at the time of the reaction? And I think having gone through the pathogenesis and looking at the fact that the even true allergy wanes, that would be why you want to know what was the age at the time of the reaction. And whether the patient recalls the reaction, if not, who informed them. How long after beginning penicillin did the reaction occur, trying to differentiate between immediate and delayed. What was the route of administration? What antibiotics has the patient reacted to in the past and even since? So if the patient claims to be allergic to penicillin and they were given penicillin at that time, but later on they were then given amoxicillin, and they didn't react to it. So it just brings to question that both these antibiotics are beta-lactams. And then what was the nature of the reaction? And if the patient had a rash, to describe the nature of the rash, trying to sort of differentiate whether could it have been an underlying viral infection at that time? Was it a delayed reaction? How long after commencing the antibiotic? And was it one of those severe cutaneous adverse reactions whereby you shouldn't even desensitize the patient if it was one of those reactions? And also trying to look at the severity. Was the patient admitted into hospital? Because often, a lot of times, patients actually do not then have an accurate recollection of the time, or they were just told. So at least they might remember whether they were admitted into a hospital. And what other antibiotic was the patient taking, and the reason why they were taking antibiotics, trying to tease out the comorbid factors or even other drugs that the patient was on. Did the reaction resolve after stopping the antibiotic? And we've already mentioned whether has the patient taken similar antibiotics to penicillin since, and what, if any, were there any reactions? So in doing this, you are trying to look at whether from history, is it a high risk of a penicillin allergy, or is it a very low risk? And then the management would be tailored towards whether it is low risk or high risk. So those patients in which the history is either too vague or also quite worrying in terms of a penicillin allergy, then you should attempt to do allergy testing. So there are serum tests and skin prick tests. So with serum tests, you've got the serum tryptase. So this particular test is done when the patient actually has just had an anaphylactic reaction. And this should be done 30 minutes up to about 3 hours after the anaphylactic reaction. And if there's a high serum tryptase, then this is quite suggestive of massive muscle degranulation or activation. And then this test is very specific for IgE-mediated anaphylaxis. But it's not very sensitive. So if you've got it, great. If not, then you still don't know. The other serum tests, there's a specific IgE, the immunocap. And these tests have got quite a low specificity and a low sensitivity. And in fact, other people just completely discourage them. The basophil activation test is usually available in some research centers. I don't know whether in any of our sites we have it, but it's also inferior to skin prick tests. So the skin prick tests are the preferred method of evaluation and diagnosis of immediate reactions. They are quite safe, very rapid, 15 minutes at the most, up to 6 hours, and sensitive and cost effective. And the results are available within 1 hour. So if you look at the picture on the first picture from the left-hand side, so the PPL there is a penicilloyl polylysine, so that major determinant factor. The positive control is histamine, and then the negative control is saline. And you are comparing it to the positive control and the negative control. So this would be a positive reaction on a skin prick. At the bottom, you've got a negative reaction because the PPL is not even similar to the saline, which is your negative control. If the epicutaneous tests are negative, you can move on to intradermal testing that is on the right there, and similar concept whereby you are comparing the PPL to histamine. Now, in some of the papers I read, they were reporting that there can be quite a problem with finding this PPL, and so just PEN-G is used. But then you would have to remember that PEN-G is a minor determinant and would only be responsible for less than 10% of reactions. So ideally, we should be using PPL. Something else that I was reading about is that, you know, these tests have always been done by allergy specialists, and ideally should be done by allergy specialists. And of course, they are done in a setting where, you know, you are ready to resusc if there's an anaphylactic reaction. But there is quite a push that these tests should be, that generalists and even infectious disease specialists should be doing these tests, because there could be quite a long waiting period in terms of accessing an allergy specialist. Any experience in this?
People can put up their hands. So I don't have personal experience. I worked in a hospital where they did used to do it, but the allergists used to do it, as you say. So I'm actually not familiar with much of the practicalities. I don't know if other people are. Are these kits easy to get? And as you said, I mean, they're sort of the reagents to do the skin prick testing.
So already in the literature, and this was in the first world, they were reporting on the difficulty of getting PPL.
Right. Okay.
Yeah.
That's not encouraging.
And then there's the second thing, that even in the first world, they were mentioning that to access an allergy specialist can be a 3-month waiting period. And I don't know about us.
Well, I mean, I think your point is well made, though, that it doesn't necessarily need to be an allergy specialist. I mean, it's not a complicated test. It just, you know, it requires some patience. So the one thing about it is it is quite time consuming. You know, you are required for safety to really wait with the patient, or at least have someone wait with the patient. So, you know, what they used to do at the hospital was that where they used to do the skin prick first, and then if it was negative, they'd give a small oral dose, and if that was negative, they'd give a big oral dose. And if that was still negative, that was fine. But that took several hours, you know, as you say, because you'd observe for an hour each time at least, and a bit longer for the oral. So it would be interesting. But I mean, obviously, if you're just doing the skin prick ones, it's shorter, it's an hour, but someone has to wait with them. I think, you know, you wouldn't want to let a patient, you know, make them be required to flag anaphylaxis. So it's tricky. But I think the first trick would be to get hold of one of those kits to actually do it. I don't know if anyone else has got any other thoughts, but yeah, interesting. Yeah.
And has anyone had patients that are allergic to penicillin and they've had to consider some of these things?
I think most people in the adult side will have had that. I mean, there's certainly reports of penicillin allergy, a lot. As you say, the experience, those when you actually test them, they're usually skin prick negative if they do get tested. So in other words, it's either not a true allergy or it's something they've kind of outgrown because it does fade a bit with time. So I think, but the self-report of penicillin allergy is pretty common, I think. Again, if anyone wants to add an experience, just stick up your hand. But yeah, I think it's pretty common on the adult side. So yeah, often a bit of a dilemma, especially without the ability to test.
Okay. So in the meantime, I will move on. So if the skin prick tests are negative, then the next thing would be to move on to a penicillin challenge. So yeah, as Jeremy was just alluding to, the fact that this is going to take up quite a lot of one's time. And patients should ideally be evaluated as when they are well, they are an outpatient, not when you've got this need for penicillin. Though even then they could still be evaluated, but it's better than to just as the patient comes to you and they tell you that they're penicillin allergic, then you should start this process. So one day when they need the penicillin, they've already been either properly labeled or delabeled. So there's different ways of doing it. So you can do the one-step challenge where you just give the full dose of oral amoxicillin and then observe the patients for 60 minutes to 2 hours. Some centers do a two-step challenge where you give a smaller dose, observe, and then you give the full dose and then observe once again. So then a negative test at this point would then exclude IgE-mediated reactions, and this patient can then safely be given the full course of the penicillin and actually be delabeled. And in fact, 95% of patients that are taken through this process of proper evaluation and testing actually end up not being allergic to penicillin. There are people, so one thing that can happen is that you can have beyond this 2 hours observation, then you can start having a reaction, a rash, and that sort of thing. And these are mainly delayed reactions that are not IgE mediated. And so some allergists would prefer to do a prolonged multi-day oral challenge, either 3 days or 5 days or 7 days. But then, largely this is out of favor because it goes against the principles of antimicrobial stewardship of giving patients prolonged courses of antibiotics unnecessarily. So patients that are positive either on the skin prick or on the oral challenge and have a need for penicillin can then be desensitized. This is just one regimen of desensitization. You can see that there's small doses that are increasing, and the ultimate cumulative dose at the bottom there that was given to this patient is 1.3 million units. So, and oral is preferred over IV, as we've already mentioned. And this can take up to 12 hours, this desensitization, with in between those different doses with 30 minutes of observation. If the patient is successfully desensitized, and I couldn't read anywhere of the degree of success, I mean, they just kind of made it seem like it succeeds in everybody, but probably that's not the case. But I couldn't find anything to say what is the success rate of this desensitizing process. So once the patient has been desensitized, then the patient can actually receive their full treatment course of penicillin. But then this is just, the desensitization is just for this course. If in future this patient then needs penicillin again, would then need to be desensitized. Unless you've had more than 10 years that have elapsed, and then you might need to do the skin prick test again to make sure that the patient has either lost the penicillin allergy or not. So even in hospitalized patients, if you are looking at that patient that has got MSSA endocarditis, you may have started with the vancomycin, but it's worth desensitizing the patient and then moving on to proxacillin and then completing that course because of the better outcomes. So what about children? So I found this study that was from Red Cross. It was published in 2015, whereby they had an allergy clinic and they looked at patients that had self-reported penicillin allergy. There were only 31 patients, so very small numbers. Their median age was 6 months with an interquartile range of 6 to 12 months. There was no sex difference, so I didn't put it there. And the time from the reaction to when they were evaluated was a median of 14 months and the interquartile range up to 3 years. So also if you're looking at the age from what we've mentioned with the risk factors and the time when they are being evaluated, that's also important. So this was done in 2011 and 2012. So what they did was they did immunocap penicillin determinants on all these patients. And out of the 31 patients, 3 were positive. And then the 28 were negative. They then proceeded to do skin prick tests on all the negative patients. They were all negative. They went on to drug provocation challenge. And of the 28, 4 were positive. 2 had immediate reactions. 1 had angioedema, the other one had a macular rash, and none of the patients had anaphylaxis. So they then reported that their overall penicillin allergy, confirmed penicillin allergy out of this cohort was 22%. But it is arguable that if you look at the fact that they included the 3 that were diagnosed by immunocap, and that has got both false positives and false negatives, that these 3 from the immunocap, it's not really a reliable indicator. So in their conclusion, and in fact, in a lot of countries in pediatrics, they now almost recommend skipping the skin prick test phase and just going on to 1-step oral challenge and under observation. And if the patient has no reactions, then delabeling them and going ahead and giving them penicillin. So in summary, I think this could be my second last or last slide. So if we look at a patient that has got this history of penicillin allergy, so you would then review the history, and just on the history, this patient could be not allergic. You're looking at a patient that either had intolerance or just has a family history of penicillin allergy. So then that patient, you would, it's safe to give beta-lactams. Just on the history, you would decide that this patient is not allergic to penicillin. Then you've got patients that have had delayed reactions. So they've either had a non-severe delayed reaction, like a rash or some itching, and there the treatment options, you could give cephalosporins, either and in hospitalized patients, I suppose, carbapenems and monobactams. And penicillin can be considered in monitored settings in these patients. And you would also consider a drug challenge. Those that have had severe reactions like severe cutaneous adverse reactions and cytopenias and organ involvement. So these patients should not be sensitized, desensitized, because even small doses during the desensitizing procedure can actually then lead to toxic epidermal necrolysis and the reactions. So in these patients, it is safe to give a non-beta-lactam antibiotic, or you can give aztreonam, like the monobactams. You would avoid penicillin, cephalosporins, carbapenems. You would avoid desensitization or the drug challenge. And then if really you want to give penicillin, it says you do it, you consult a specialist. We call Jeremy when you need to do that. And then you've got the patients that have had immediate reactions from the history. You consider that it's a potentially an IgE mediated reaction. So the ones that have had non-severe reactions, you would then either give them a non-beta-lactam antibiotic or aztreonam or carbapenem. You could also go on to actually test them to see whether they are penicillin allergic. And then for the severe reactions, you should give a non-beta-lactam antibiotic or the monobactams. You could also then look at non-cross-reacting cephalosporins and carbapenems. And then in monitored settings, you would then consider the testing and the drug challenge as described and desensitization as necessary. That was my last slide.
Great, thank you very much. Thanks, and thanks for setting everyone to me every time they have a penicillin allergy patient. No, I'm not an expert in this, but yeah, it's a fascinating topic. And thank you so much. You've done a really great job of summarizing so much of actual clinically and practical use. So please do ask any questions you may have from the audience. You just type in the Q&A there and I'll get to it. But yeah, I mean, I think the key things with the desensitization are, as you said, to emphasize it's temporary, obviously. It only works while you keep taking the drug. As soon as you stop it, you go sort of back to where you were pretty quickly in the next few days. And then, as you rightly say, it's only for the immediate type hypersensitivity reactions, because it's really trying to fatigue the mast cells more than anything else. And yeah, I think that's excellent. And then there's that one, you did have it in your slide, but it's a great piece of ID trivia that comes up sometimes in MCQs, is that if you are, because you can usually, if you're allergic to the beta-lactams, you can usually, as you say, give aztreonam, with the exception of if you're allergic to ceftazidime, which is the only one, because it shares a side chain. Yeah. Yeah,
that shares a side chain with aztreonam.
Absolutely. And so obviously, although the beta-lactam ring itself is usually the allergen determinant, not the side chain, there is a chance. So if you had a severe reaction, you'd ignore it. It's a tiny piece of trivia. We do have aztreonam, obviously, in South Africa, not available in the state sector, at least as part of an EML drug, but it is available. It can be gotten. Yeah, I'm just looking through in terms of any questions from anyone else. Sorry, just let me scroll for a second here. Oh yes, in terms of the pseudoallergies. So thanks for bringing that up. That's really, really helpful. It's one of the kind of constant frustrations of someone who gets a bit of chills after amphotericin or something like that, or a number of the other examples you used, and trying to convince them it's not actually an allergy, and just please go on. If you need to give the next dose, continue. Just do it a bit slowly and maybe give them some pre-meds. And yeah, I think you mentioned the poor outcomes excellently. And and then just from my side, the multiple antibiotic allergy syndrome. I don't know why this is, but it seems to often be present, as you said, in certain types of people, and they are absolute nightmares. I once had to treat a patient who was allergic to, I think, 9 different antibiotics, which covered pretty much every class. So it was not just the penicillins. We sat with 3 consultants trying to work out an antibiotic regimen for her osteomyelitis. It was quite a scary thing, but it does happen, but fortunately very rare. And yeah, I think you've galvanized us to try and see if we can look into organizing these sort of allergy testing for state sector and for private as well. I mean, I think, outside of an allergist, or it really does, it is something we should perhaps look at, because the benefit is so big. I mean, the key point you mentioned there, 95% basically of people who say they're penicillin allergic come up negative if you test them. That's really the key thing to keep focusing on when you consider the bad outcomes of people who say they're penicillin allergic. That if you could exclude it, it really does help the patient a huge amount. Great. I think that's all we've got time for.
Any comments from the pediatricians in the group, or people with that work with kids? just experience on how many of our patients report this penicillin allergy.
Do you want to pick on anyone, Nosisa?
I can't see who's in the group actually.
Ah, sorry. We've got it's
I think
so
Kosi
mostly
might
quite
be
good.
here.
Oh, no, I think they're hiding from us, Nosisa.
Yeah, they're hiding. As I say, you know, my patients say they are allergic to tin fish.
Yes, which is an unusual allergy, but it's enough to get the radiologist to cancel all the CT scans, I find, in my experience. I've got a comment coming through here saying Morganella causes scrumboid poisoning, fish allergy diagnosis. That's interesting. So in scrumboid, scrumboid, I know, you know, that's, but I didn't realize it was associated with Morganella. That's interesting. That's fascinating. So again, it's not really not a true allergy, I suppose. It's really just the mast cell degranulation. Fascinating. Cool. All right. Well, thank you, Nosisa.
Okay. Thanks, everyone.
And yeah, really nice practical session.